Yeah, ma'am, we are on live and
We
we are
are on
starting
live.
session, ma'am. Yes, ma'am. So, very good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's topic on the icons in conversation with Dr. Ritu. The topic for today's session is current concepts in management of borderline ovarian tumors. I'd like to welcome the chief guest, Dr. Rajeshri Katge ma'am, and our Dr. Ritu Santwani ma'am. I would like to introduce Dr. Ritu Santwani ma'am. Madam has done
Yes.
yes, MD, FICOG, FIAOG, and AMR COG. Madam has done her EIT training from Singapore. Madam is well-known obstetrician, gynecologist, infertility specialist, sexologist, and cosmetologist, founder and CEO of 360-degree Healthcare Studio, renowned professional with more than 20 years of experience in medical field. And Madam was also the co-founder of MOM and board member of WSCG. I would like to invite the guest for the day, Dr. Rashi.
Bus. I'm just
please.
Ma'am,
No,
ma'am,
please,
just
please,
I'll
please.
give you a
Yes.
light introduction. Madam is the professor and head of the unit Department of Obstetrics and Gynecology, Grand Government Medical College, Mumbai. Madam has been an active member in academic and various committees. Madam is worked as a principal investigator at ICMR. Madam has done more than 100 plus publication with 240 plus citations in national international journals with 1 lakh plus global reads. Madam has received various awards and appreciations for her service. And Madam has
bus Stalin बहुत हो गए जाने
yeah, ma'am. So with this short introduction, I welcome you, ma'am. I'm handing session to Ritu Satwani, ma'am, for the proceedings, ma'am. Welcome, ma'am.
Yes. Thank you, Dr.
Thank
Stalin.
you.
Dr. Stalin, please display the Dr. Katke CV. I want to welcome her. Huh?
Yeah, ma'am. Sure.
Yeah. So, hello everyone. As all of you know, this series, the Icons in Conversation with Dr. Ritu. So, in this, every week I'm inviting one stalwart, and today the stalwart is none other than my very dear friend, Professor Dr. Rajeshri Katke. So, for Rajeshri, I can say only one line. She is the ocean of knowledge. Whatever you want to ask, she is the master of the subject. And one very important thing for her, she is always ready to help. So this is her best quality, whether in the academics or non-academic field. So Rajeshri, I think you are one of the Mata Rani blessing in my life. So I'm really grateful to you.
Thank you.
Yeah. She is always ready, friends, as we have just introduced Madam as professor and head of the unit of the Department of Government, Grand Government Medical College, Mumbai, a very well-known figure. And I'm so grateful to her whenever I request Dr. Rajeshri that you have to come for one lecture. In spite of having her very heavy and hectic schedule, she never says no to me. So I'm really grateful to you, Dr. Rajeshri, that you are helping me a lot for spreading this knowledge. So now for 2 weeks, we are having consecutive series with Dr. Rajeshri Katke Madam. So today she is going to discuss about the borderline management of the borderline ovarian tumors, and next week we are going to discuss about the CA vulva. So whatever the queries in your mind, so this is the very golden opportunity to ask the madam. So abhi jo bhi queries hai, please likh kar rakh lijiye. Whatever you forget to ask today, we can connect again on the next week on the same with the another topic of the CA vulva. So now, without wasting much time, I am handing over the dais to Dr. Rajeshri Katke. A very, very warm welcome, Dr. Rajeshri.
Thank you so much.
And we are really grateful to have you with us on this platform. I think those who are the regular watcher of this program must have seen, I have done earlier also a lot of sessions with Dr. Rajeshri. In the Corona time also, all had gone very well. So again, once again, welcome.
Thank you very much for the kind words, Dr. Ritu. You yourself, it's a gem of person, and the word gets lesser. The amount of the work you are doing into the field of this academic platform, and also with the what we can say is that for our fraternity, just giving the knowledge and doing selflessly, it is the greatest recognition and I think you are doing wonderful job, and claps for that also. And thank you so much. On the contrary, I always feel, very delighted whenever you call us, and it's basically you are giving us the opportunity. Thank you so much. Can I share the screen?
Yes, please.
Yeah, thank you.
Just a second, and welcome all our delegates. I am able to see some friends have joined from the Egypt and some from the Saudi. So program is going live on the YouTube. Later on, I will share the link with Dr. Rajeshri Madam also, so she can also post. Yeah.
Yes. Yes. At many times they have been called me to talk on this topic. So whenever I used to finish it, the lecture or the panel, and also many of them, they used to come with this, queries and all those things. And this is the one topic where I always, I feel to present or do the lectures and all, because it is very, very important. We are doing all the things with the era of the laparoscopy, and all of us, we know, with the infertility treatment, with the young patients, with the ovarian tumors. So this is the borderline ovarian tumor, and I have just divided into three. What is this surgical role and the infertility management? So I'll start off that. So basically, by the definition, the ovarian tumors that demonstrate the higher proliferative activity compared to the benign neoplasm, but do not show the stroma invasion. That is very, very important. Risk factors being overweight, unopposed estrogen, and the genetic factor. Protective factors are the increased parity and the breastfeeding. The introduction, this I would like to say, is that before the 1971 also, whenever they used to feel that there is the borderline ovarian tumor entity has come and it has been qualified as a low malignant potential tumors by the FIGO since 1971. Their incidence is low and is calculated in the European series around 4.8 per lakh new cases per year. They occur mainly into the most of the middle age or the reproductive age group also, and in that the percentage is around 27 to 36%. So let's have a brief of that, not to go in the detail. The ovarian tumor, they are classified, everybody knows, in the epithelial, germinal tumors and the sexual cord tumors. And apart from that, 65 to 70% of the bunch of the epithelial tumors, 10 to 20%, they are the borderline. And in that, the major chunk is around 53 to 60% is a serous, and the 30 to 42% mucinous, and others, they are less than 5%. This is the carcinogenesis. Just I want to just mention in that one is the mucinous endometrioid, serous mucinous endometrioid, clear cell, and the Brenner. See what happens in that. In everything is that whenever there is one benign going into the transition of the malignancy, the tumor in that. So basic thing is the mutations in the BRAF or the KRAS pathway. And this serous borderline tumor, they will get some of the potential to develop into the higher activity and the low grade serous carcinoma. This is very important to know in that. So just have a brush up with the FIGO staging. Stage 1, tumor confined to the ovary. Stage 2, peritoneal implants within the pelvis. Stage 3, peritoneal implants beyond the pelvis and the positive lymph nodes. And 4th is the liver parenchyma involvement for tumor beyond the peritoneal cavity. Everybody knows in that how the patient will present in that. The abdominal pain, 80% abdominal pain, discomfort, tense abdomen, bowel irregularity. 50% have the gynecological symptoms like dyspareunia, menstrual irregularities. Then 10 to 35% GIT symptoms, 5 to 26% urinary symptoms, 5 to 7% general malaise, and the weight loss. Women with borderline ovarian tumors reported significantly longer duration of any symptom. So such patients, if they are coming repeatedly to our clinics, then it is our way to look that is there anything to do the best clinical examination. Ultrasound will be needed for such patient. So this is the clinical. Then how to diagnose? One is with the clinical presentation, then the good examination per abdomen if the mass is huge in that, PV examination, per speculum examination, see for any adherency, even the per rectal examination to know any there is a nodality with the uterosacrals and all. And after that, the main thing is this role of the ultrasound. If the big tumor is, go for a transabdominal. If small are there, one should go for the transvaginal route also. And when the ultrasound is there, always go with the Doppler images. The serous and the endocervical, like mucinous borderline ovarian tumors, had similar sonographic features like small diameter, fewer localized, higher number of the papillary excrescence, higher color scores inside the solid component than the mucinous BOT of intestinal types. So basically, the most important is that irregular septae and irregular inner walls due to tumor deposits in the young women. So whenever the ultra patient come with all these reports to us, then we should read all these and we should think in the mind, though you feel that clinically she is young and all, so we should go for, further investigation. Serous BOT can be further divided into a typical pattern around 90% and the micropapillary pattern 10%. This is very important to have for the prognostic criteria. Micropapillary pattern has a worse prognosis with presence of invasive implants. So a very good ultrasound with a Doppler effect and with experienced ultrasound specialists, they can give even the idea about a completely benign or there is a suspicious nature of these ovarian tumor. So with a higher rate of recurrence in a bilaterality of the tumor. So this is very important to know. Therefore, malignancy is more closely related to the presence and invasiveness of the implants. So this I'm covering the points in that because most of the times the whenever the ultrasound such comes, many of them, many of our colleagues also, they talk to me or they call me what to do in these, because for last 20 years I'm also working into the gynec oncology field. So sometimes they are always worried to know about the peritoneal implant. So about 20 to 40-60% of the serous BOT have the peritoneal implants. These have been classified into invasive and the non-invasive categories. See, invasive, you have to worry. Non-invasive categories, you should not be, not much worry about that. And this again classified into the epithelial or the desmoplastic or both. So according to the FIGO and the WHO guidelines, the diagnosis of borderline is based on the histological features of the ovarian tumor, regardless of the appearance of the extra ovarian disease. This is a very important thing. What it has come in that previously all suspicious tumors used to be before 1971. They used to think, if this is the malignant, even it is in the young, and most of the time the radical surgery has been taken it out. But this, with the evolution of the science technologies, and there is a development into the good histopathological things, and they have created a group of BOT, and that has been made a great revolutionized things in the management of the ovarian tumors. So serous BOT microinvasion, if it is there, then there is a strong association of the invasive implants. So let's have a look. We have collected of our these things. These are the borderline tumors. See, you can see a micropapillary in that solid tumor with papillae and rather smooth inner cystic wall. These are the regular septate, and there is an unequivocal intracystic fluid. So such pictures comes, then you should go for the, if there is anything wrong with the tumor, then we have to again do the tumor markers and all. And about the mucinous, this is the one variety which is always, we should get very careful about this. In the mucinous, you will see in that the multilocular solid tumor with larger number of the endophytic and exophytic tumor papillae and the high intrapapillary fluid. I remember one of case where I have taken around more than 20 kg of the mucinous tumor, but there it was a benign. We did a frozen section for that, and it was not even the borderline malignant ovarian tumor. Patient was around 45 kg. In that 20 kg was the tumor. and such was huge because she was not able to get breathing also, but that was a benign in that. So when we opened the abdomen, the all jelly-like material was there, and there were many these papillary things, highly vascular things were there. I have put it on my YouTube also, and it's very scary thing. So in the mucinous intestinal type BOTs have different sonographic features. Either it could be unilateral, large 20-22 centimeter, or the multilocular tumors. But the presence of bilateral mucinous tumors suggests the possibility of the metastatic tumor from the another side. So we have seen also that there are the bilateral tumors where they get involved in that. And basically we should know about whether there is any focus in the primarily in the gastrointestinal tract. That's why we do a prophylactic appendicectomy when we see the even with the mucinous type of this thing. So mucinous borderline tumor, see how it is looks, all this cyst and all this, and this is like a honeycomb nodule. So you have to see in that, see for the blood flow, and then intracystic fluid of low level of the echogenicity. So this is very important because patients, they are coming with the ultrasound reports, patients are coming with the plates, and if you see such things, then it should come in your mind also. Then after ultrasound, the MRI you can do if it is required, or the CT scan if there is you feel that there is a extra ovarian disease is there, or you have any doubt in that, if there and if there is a borderline tumor with highly rise of the tumor markers, then when suspicious is there, or even with the routinely to CT scan we are doing at our this thing. But sometimes the tumors, they are very huge, it's very difficult to differentiate in that, to get the exact idea about the plane and the origin of the tumor or the site of the tumor. MRI is also very good in that. So gross appearance of the primary ovarian tumors, this is serous. Sometimes you will get a bilateral in 30% of the cases. This is a very important thing with the current concepts, how the lymph node involvement. There are para-aortic and the pelvic lymph nodes also. Involvement is present in 7 to 23% of the cases on node sampling, because still it is the area where not a large data has been published, but many centers, they have done like 131 cases, 5 years 7 years study in that and all, and they are coming with these things. But let us see what is the importance of the lymph node involvement. We will see it later. And mucinous, they are the intestinal, majority of these are the unilateral tumors, and the second is the endocervical or the Mullerian, and we have seen such cases where there is a association of the endometriomas or the pelvic endometriosis. We have been seeing, last 20 years, there is so much of the development in the infertility treatment, so much of the development in the various hormonal line of treatment. The sedentary lifestyle is there. The epidemiology has been changed. With that, the most of the clinical scenario, they are also changing with the patients, and we have to also update this knowledge with us. So I think these I have included all these the practical points in that. So because for the BOT, most of the patients, they are coming to the gynecologist and they have been treated with that, and after the report comes like that. So though the diagnosis is depend on the histology, but suspicion of all these things has to be kept in mind as a clinician. So the role of the tumor markers, elevated CA125 levels in 15 to 50% of the patients with BOT, and this is routinely also whenever inflammatory conditions, tuberculosis is there, the CA125 goes in high in that. But Angelin and the colleagues evaluated the role of CA19, not 9, in the BOTs, and concluded that this marker might be more useful in the diagnosing the mucinous tumors. Again, the alpha-fetoprotein and the beta-ST, if you have other part of the other germ cell tumors or the others variety of the tumors. So BOT is classified according to the FUGO classification. We have seen in all these things, but what the good thing is that in the early stages, 70 to 80% are diagnosed at the stage 1. About 20% present into the advanced stages. So the patient, they are coming. If you have a doubt, you can go with the further investigation. Diagnosis with the histology, this I have been included, or this slide is because it also depends, the prognostic criteria, it depends upon in that also, and how you should look for that. Sometimes we have done a cystectomy and the histopathology reports comes like that. If there is a mild nuclear atypia, then increased nuclear cytoplasmic ratio, slight to complex branching or the bridging of epithelial papillae or the pseudopapillae, epithelial budding and cell detachment into the lumen. But these are the things which goes in favor of the borderline tumor, but there is no destructive stromal invasion. That is very, very, very important in that. This is just, I haven't just explained to you endometrioid, clear cell and the brainer. This is the diagnosis. What are the other tumors and how they look in that, and how we should go ahead with the diagnosis part. Let's come to the management of the borderline tumors, the role of the surgery. The management of the borderline tumors, the majority of patients with the BOTs are frequently diagnosed during their reproductive age group. For these patients, the therapeutic decisions regarding the fertility sparing surgery is very, very important. This is the one thing which I have been liked, and I feel this has become a wonderful transition in the management of the ovarian tumors, because this fertility sparing surgeries, it is the one of the best thing which has happened to the young patients which want for the treatment for the fertility or for the this thing. Treatment of the infertility or the premature hormonal deprivation. This is again an important thing. How we are going to the management is that these are the 2-3 points I have taken it out. Then intra and post-operative morbidity. Adjuvant chemotherapy treatments are particularly pertinent. So approach of the surgery, we have a laparotomy, laparoscopy, and the robotic one. The role of the conservative surgery is that the recent literature are reassuring regarding the efficacy and the safety of the conservative surgery. So there are 2 conservative surgeries. One is the unilateral salpingo-oophorectomy. Second is the cystectomy, involving the preservation of the uterus, at least a part of one ovary, with comprehensive surgical staging for the borderline tumors of the ovary in all stages is also very important. So for the conservative, USO and the cystectomy. So the conservative surgery. Suppose there is a bilateral ovarian tumor, what you will do? At least if you want to take it out, ideally you should conserve the part of the ovarian tissue. But in some rare cases, what it happens is that you're not able to keep the tissues. You don't find tissues which are healthy, or the disease extensive and all. And in those cases, at least the uterus can be preserved for the eventual transfer of the frozen embryos obtained before the radical surgery. See, this is the best evolution which has been occurred with the change in the epidemiology of the oncology in a young woman and developing the treatment of the infertilities. And this is the best thing to happen in that. So in the fertility sparing surgeries, I have already, I think, included this. Then comes to the surgical approach. See, laparoscopy, it is the one of the best method. You will get a less adhesions, then good recovery, then most frequently use of the conservatively treated these things. And most of the things, patients, they are coming with the ovarian tumor. We diagnose for the diagnostic laparoscopy, and after that, whenever we see in that, then we go for the, we think that if it is a benign, we go for the route of the laparoscopy also. So here I would like to, as a part of my experience, I would like to tell one thing is that, because many patients, they have come to me whenever there is, patient has gone to the laparoscopy surgeon and they have done, the cyst was ruptured and cauterization, and after that the reports comes in some part with the microinvasion and some part of the borderline or some borderline ovarian tumor. So this is the one thing. So I feel whenever you put a scope, you feel that this ovarian tumor is quite a large one. There is papillary excrescence there. Doubtful thing is that solidarity is there. Then don't do a cystic rupture. Ideally, what you should do is that you should have a frozen section, the facility if you feel in that, or you can do with the endo bag. And that is the caring thing is that, because whatever the world reviews are there, they say the higher recurrence rate, was observed in the laparoscopically performed conservative surgeries. So laparoscopy, the systematic use of an endoscopic bag and abundant copious peritoneal washing. It is the most important thing is that this I have, included the study of this serically reported 19 patients of the BOT were treated by the conservative laparoscopic approach. And after that, he has seen is that 11 had cystectomy, 8 had unilateral salpingo-oophorectomy. But he found that if sometimes previously people used to do a contralateral biopsy of the, other ovary, but that is not recommended nowadays. So in surgical approach, definitely laparoscopy, lower morbidity, fewer adhesions, and which are important for the fertility. The laparoscopic management of the borderline ovarian tumors are associated with the higher rate of the rupture and incomplete staging. This is so very important in oncology. Whenever you feel that a suspicious, either high staging or the understaging is not good for the management of the patient, mean good survival. 5-year survival. All laparoscopic procedures should be nevertheless be performed by the whenever you are doing with the laparoscopy, any doubtful ovarian tumor, if you see in that, always keep an eye like oncologist, or if you want to do a surgery on that, at least the laparoscopic procedure, if they're doing it, then you can keep standby, or you can develop skills of yourselves in that, because most of the times when we feel that cystic and then we rupture, sometimes endobag is not there. So whenever a suspicion and doubt is there after putting the laparoscope, then you wait and do the everything properly, because the optimal surgical staging and complete debulking gives the better results in terms of the both relapse-free survival and the fertility preservation rate. This is very, very, very important. Unless you do a good clearance, it is not going to give the benefit. Leave apart of the fertility preservation rate, but still she should have her, free survival, or the quality of the life is also very important in that. Cystectomy. Ovarian cystectomy should be considered women with one ovary, or there is a bilateral ovarian tumors are there. What are the advantages? You can keep the removal of the less ovarian tissue, and you can keep some of the preserve the ovarian tissue if it is needed in that. Whenever you feel that it is healthy one. But many studies have suggested that the bilateral cystectomy is associated with an increase in a recurrence rate. But you have to weigh the pros and cons, the age of the patient, then in fertile status, and if she wants to go for the childbearing, or about the other things, if there is any extension of the extra pelvic ovarian disease. So ovarian cystectomy can elevate the risk of rupture and intra-abdominal spillage in 70% of the cases, which is associated with an increased relapses and contamination of the abdominal wall. So never do that in a doubtful cases, whether the tumor is small or the large one. Ovarian cystectomy can elevate the risk of cyst rupture and intra-abdominal spillage in 70% of the cases, and various studies are there. And I have included the biggest one is the Poncelet et al. In 2006 found a higher rate of rupture in a laparoscopic surgery compared to in a laparotomic surgery. Cystectomy, we are finished. Then comes to the unilateral salpingo-oophorectomy that provides a safe therapeutic treatment for BOTs in women wishing to preserve the fertility, and should be considered as the first choice of fertility sparing treatment, and for the massive involvement of the ovarian parenchyma when it is not possible to preserve healthy ovarian tissue. Many of the times it is the on-table decision that you are not able to conserve the ovarian tissue or the preserve the healthy ovarian tissue, then you have to take the decision of unilateral salpingo-oophorectomy. But this gives the less recurrence rate. So recurrence after the conservative surgery, this is the one very important thing. The available data suggests that the rate of recurrence is higher after conservative surgery, that is 10% to 20% versus approximately 5% for the radical surgery. But here in BOT, we are doing the conservative surgeries, so we should also know what is the what is the future recurrence rate of that also. And this is very important. Patient can come and ask to us also after the histopathology report, so what is my prognosis, or what is my quality of life? So all these questions, it will come to the gynecologist also, the oncologist also, and the infertility specialist also. The recurrence are nevertheless almost always from the borderline tumors and are found on the spared ovary, but not the invasive disease. The recurrence after the conservative surgery, it depends with early stage disease. The extra ovarian recurrence only occurs in 2% of patients compared to the 20% of the cases with advanced disease, FIGO stage 2 and 3. Conservative management should be limited to a select group of the patients with complete resection of the peritoneal spread and the non-invasive implants. Implants are very, very important, peritoneal implant. Recurrence after cystectomy. How one should go ahead with that? We know that there is a higher recurrence rate up to 31%. For that reason, cystectomy should be performed only for patients with the bilateral tumors or only with the one ovary. The use of cystectomy is not safe in patients undergoing conservative management for the mucinous. This is very, very important. I would like to say is that if you feel that whenever you have opened or you have put a laparoscope and or the robotic, you are doing it in that, you find it in the mucinous, because the mucinous has having the higher rate of the recurrence. That is one thing. And second thing is that sometimes if it is of the primary intestinal origin, then again it becomes difficult and we have to investigate the patients and go according to that. Role of lymphadenectomy. Pelvic and para-aortic lymphadenectomy is not required for disease staging. This is very, very important for our ovarian tissue diseases. Whenever we are getting cases of the CA ovary, in those cases, always we should go for the lymphadenectomy, omentectomy, and everything in that. For the studies they have been published, they have been seen in that there is a pelvic and the para-aortic lymphadenectomy is not required for the disease stage. Recent studies have suggested that lymphadenectomy can be omitted even for the advanced disease in a borderline ovarian tumor, because there is no difference in recurrence or the survival rate. They have found it. Again, every time there are many, because not much larger studies and much larger data are not available. There are many studies I have gone through, and I'm following this subject in the last 10, 15 years, treating the patients also. So in that, we are not doing the lymphadenectomy. The role of lymphadenectomy is limited to research at the best settings. The pelvic and the para-aortic lymphadenectomy is not considered necessary because there is no significant improvement in the recurrence rates. That is one thing. The lymph node involvement does not decrease the survival. That is the second thing. The lymphatic involvement, despite having no prognostic value in BOTs. So recurrence or progression to carcinoma in this area is exceptional. So we are not doing it with the lymphadenectomy. Therefore, it does not justify the morbidity associated with the systematic lymphadenectomy. So this is the thing in that. So what happens if suppose we have done, what is the role of radical surgery, when we should enter the radical surgery in cases of the borderline ovarian tumors? So patient is postmenopausal, or you have done I think some disturbances are there.
Sahiti, please mute everyone except the speaker.
Yes, I think there is a okay. So this is very important. We are talking about the conservative, but 1 to 2% of the cases with the patient, they are coming with the recurrence or the reoccurrence of the disease. In that cases, you have to go for the radical surgery. But in that also, we should divide into the, either we can go if patient is young for the conservative or the complete radical. So in the radical, a thorough exploration of the abdominal cavity, we know all these things: bilateral salpingo-oophorectomy, inframesophilic omentectomy, peritoneal lavage to obtain and resection of the macroscopically suspicious lesion and the multiple peritoneal biopsies. So this is about the these things. So surgery after the recurrence of that, Either you should go for a conservative if she is less than 40 and wait, let her go for the fertility, and you can wait, but you have to counseling and the telling is very important in that. And if suppose the fertility option is not there, the disease is progressing more than 40 years, go for the radical. The surgery after recurrence, this will be with extra ovarian borderline or the invasive relapses occurs with the cytoreductive surgery as with the primary ovarian cancer. It should be treated. Now it will go to like a CAORI. So let me focus on the data. The available data suggests that the rate of recurrence is higher after conservative surgery in a BOT, but approximately 5% of the cases go for the radical surgery in that. The extra ovarian recurrence only occurs in 2% of the patients compared to the 20% of patients with the advanced disease. So whenever the patient of a BOT coming with the advanced disease and we have done a conservative surgery in that, those cases, they may go very early and likely to go to the extra ovarian recurrence. So need for staging. Just 2 lines for that. Recent studies have questioned the benefit of staging, so especially in the absence of the gross extra ovarian disease. So for the borderline ovarian tumor, we are not doing the need for the staging, but you feel that as there is no difference in the prognosis among the stage and the unstaged patient. But if there is a recurrence is there, multiple invasive implants is there, then routinely how we do a staging for CAORI, we can do a staging like that only. And laparoscopy seems a safe and effective alternative in reducing the invasiveness of restaging. This is for radical surgery. This is the preventive. Now we are doing with the hysterectomies, or in that also conservation of just radical fimbrectomy. We are doing it with that because we say that with the fimbria, keeping the fimbria and the environment value in that, that is one of the precursor for the CAORI. This I would like to, this is my own experience. She was a professor. Patient has come with 14 weeks of the pregnancy and she has a solid tumor in that. She went to the couple of the places and they have been said because tumor markers very high, she was not ready to continue the pregnancy. So we did the, with her consent, the pregnancy was terminated, and after that with the CT scan there were no lymph nodes and all in that, and this has been patient has been open up with this, and we did because they said it is like a neoplastic etiology, and this is unilateral salpingo-oophorectomy. She was young, 27 years professor she was. Then I did this and I did a frozen in my operation theater, and they said borderline. Patient also said to go for all these things because frozen is always never is also 100% diagnostic in that. After that we followed up, and I give her induction of the ovulation, and with 2-3 cycles she conceived and continued with 9 months, and she delivered a healthy baby. So there are many, but this very nice and interesting, and patient has followed up also the case in that. This is some of my OT pictures in that serous borderline tumors. This is the mucinous. You can see the honeycomb like appearance on ultrasound. It gives in that multiple cystic in this, and this is for the cystadenoma. This is the brain, a huge brainers tumors in a young patient we got in that. So this was also borderline in that. And this is a ovarian fibroma. One patient has come with this, and they have been treated, put a scope in that, and there was no fibroid, and this was, a doubtful solid tumor from the ovary. And then we remove it around this thing, and it has come as a ovarian fibroma. This is clear cell ovarian malignant tumor, because I have not seen a borderline tumor with a clear cell, but this is a malignant. But these are the clear cell malignant. If the borderline progresses into the malignant, or you borderline, you operate, you have to do a meticulous follow-up because they don't have a very good prognosis. So let's have a look. I think master is Dr. Ritu madam and this thing, but let me have some points, and again she will highlight on the topic. So most of the spontaneous conceptions, 50% of the patients, you can correct me, Okay. Spontaneous conception is reported after the conservative surgery in 50% of the patients. Until more data from the larger prospective cohort studies of IVF treated women with prolonged follow-up. So basically, one important thing is that in these cases, you have to counseling is very, very important in that, because they will ask you multiple questions. They are very scared of that, whether there will be a malignancy, whether she will conceive, when she will conceive, whether she will have a healthy baby, and after that, what is my prognosis, what is my life. So these are the so many things in that. So fertility options in women with the borderline tumors are that in vitro fertilization, IVF, current fertility sparing methods, then cryopreservation of the ovarian tissue, oocyte cryopreservation, most of the people they go for this, and the future fertility sparing methods, in vitro ovarian follicle growth, in vitro ovarian follicle maturation, and protection against the germ cell damage using the phytoprotective agents. I think this is the very important thing to in the field of the IVF, this thing. And suppose everything is not there, if the patients they are willing to go for this complete surgery, and they want to go for adoption, that is also one of the best adoption. And last one is the surrogacy, if she fits into the surrogacy law. Fertility treatment, ART techniques, ovarian stimulation, in-vitro fertilization, cryopreservation, most of these are the very debatable things. Not single one is very better than the other. I think Dr. Ritu, I will ask her afterwards and she will highlight on that. So, but one of my friend, she is also working in UK in one of the best of the infertility center. So whenever we used to discuss, so she used to say that they are doing very good with this, with young BOTs, cryopreservation and all, and that is the future of in that. So that is the one thing. So the procedure of the oocyte retrieval is associated to the rare but clinically relevant risk of hemorrhage infection. You have to explain to the patient, is ovarian stimulation is safe in that? This is very debatable. I have gone all the most of the studies in that. So because most of the, if you do the multiple stimulation in that, so the more chances of developing the malignancy or all those things, or the cases they are coming with the recurrence rate. So this is the very debatable, but most of the studies, they found that it is quite safe if you are doing in cases of the BOT. In some studies, there are rare cases where they have found the recurrence rate. In some cases, they said there is no difference if you give the ovarian stimulation, but it depends upon how much you are stimulating the ovaries. That is also important. Then comes to the embryo cryopreservation. Since 1983, with the first case, embryo cryopreservation is proven method of the fertility preservation. So, but can be performed only if there is no therapeutic urgency of at least 2-3 weeks is usually necessary, because you have to go for the ovulation induction protocols. And then after that, embryo and formation of the embryo and the cryopreservation. So it will take some time, but in emergency, it is very difficult. So suppose if you open up the case and you found all these things, extensive disease, then it is very difficult to go for that. So oocyte preservation could be a valid option for patients with unilateral ovarian malignancy. Oocytes could be acquired during the unilateral ovarectomy. So some people, they go for that. Some people, they said no on that, because controlled ovarian hyperstimulation, there are various different protocols also. Protocol for the ovarian hyperstimulation for the healthy women is different, and for the infertility cases, in that also they give the ovarian hyperstimulation and early intervention or in a prepubertal patients, because here what they want is that immature oocytes are acquired without the need of the stimulation, subsequently are matured in vitro either before freezing or after thawing, because their concept is that the immature oocytes are more resistant to cryo injury than the mature oocytes. That is the one thing that depends upon the future prospects for the fertility things. As compared to the at least 8 oocytes are required for patient age less than 38 and more than 8 oocytes in patients more than 38. Compared to the embryo cryopreservation, oocyte freezing is still associated with lower pregnancy rates. This is not my experience, but this is the world literature says. ovarian cryopreservation. Ovarian cryopreservation can be offered to patients who require early treatment and those who have been hormone sensitive tumors. In fact, no ovarian stimulation is required for the prepubertal patients. But one important thing is that if suppose the patient is BRCA carrier or the BRCA positive, in those cases, you cannot, do the ovarian cryopreservation. Developing 30 protective agents has been long studied to protect the oocytes against the radiation and the chemotherapy. The GnRH antagonist and agonist are used for this function. There are many others also in that, but the role of temporary ovarian suppression with GnRH analogs during chemotherapy has been accurately studied for the past years and the contrasting. This we have experience in our CAORI cases and the borderline cases. Treatment of the hormone deprivation, hormone replacement therapy to prevent the cardiovascular disease if it is required, for not for a BOT, but with the recurrence if we do extensive surgery in those cases. Adjuvant treatment, which is non-beneficial because response to the usual cytotoxic agents is low, probably related to the slow proliferation. So we are not giving the chemotherapy in that. The role of the chemotherapy, there is no clear evidence that chemotherapy can decrease the relapse rate or the improve survival rate. So we are not giving the cytotoxic drugs because it is a low proliferation rate in the BOTs. But suppose there is a very much of the recurrence is there, and in those cases afterwards in a radical surgeries, if they go into the CAORI progress in that, then there is a role of this thing. Because in a young patient, the alkylating agents are the gonadotoxic and chemotherapeutic agents and have most of consistently been associated with the ovarian failure. It's different. There are many studies in that alkylating agents, they are doing the irregularity of the menstruation, then AMH levels also, they are very, low in such cases. So you have to go with the case, individualization of the case. Factors of BOT prognosis. So which are the bad ones? Missinus, invasive implants, papillary pattern, incomplete surgery, microinvasion, conservative surgery, intracystic carcinoma, which is missed and age more than 40, and the extra ovarian relapse. The factors that suggest a higher rate of OT, invasive BOT, invasive recurrence. The serous BOT mostly is invasive implants, and there is stromal microinvasion or micropapillary pattern with intraepithelial cancer. So these are the sometimes we feel that we have done a borderline ovarian tumor, we have taken the frozen section, or they have taken the sections. But the histopathologists, they take the sections, and one section afterwards they found that there is stromal microinvasion. Then we have to take for the invasive recurrence of that. So what is the prognosis in that? So 60% chance of having stage 1 disease. When diagnosed, post-operative treatment for any stage is controversial. Adequate staging is essential for determining the prognosis. If suppose you find it is an extra ovarian disease in that. So basically, prognosis is good. We will come later in that. Role of radiation. So we don't have found any role of radiation in that. Only the radiosensitive most tumors like a germ cells, and they are having they are coming with the recurrence of the borderline ovarian tumor, then there is a role for that. So follow-up, how we should do a basic good history, clinical examination, ultrasound, CA125 serum levels, CA 19.9. So close follow-up for first 2 years is very important in that. She can come by monthly for 3 months, then 2 monthly for 6 months, and then after that 6 monthly, and a long follow-up is needed in such cases. So follow-up include the physical examination, ultrasonography, tumor markers, and required if there is a extra pelvic disease is there, then we have to go for the other investigation like MRI, CT scans. To conclude, in conclusion, conservative treatment of early stages of BOT results a high pregnancy rate and the low recurrence rate, as well as the low risk of death from the disease. USO may provide a safe therapeutic treatment for BOTs, men wishing to preserve the fertility. And ovarian cystectomy has having the rupture of the cyst, and one should go, the rate of recurrence is more with that. So in conclusion, a final comprehensive restaging has a minor effect on the clinical management and outcome. No further radical surgery is generally needed. Patients with advanced stage has an excellent prognosis if the tumor does not have the invasive implant. Therefore, the fertility sparing surgery should be considered for patients with a strong desire to become pregnant if there are no invasive implants or if there is no extensive disease spread. Ideally, one should give the option for them and individualize the case and the rate. So, in a nutshell, suspected borderline ovarian tumor, ovarian cyst of unknown dignity, laparoscopy or somebody doing laparoscopy, intraoperatively histopathological examination, whether if it is a benign tumor, go for a conservative. BOT, fertility preservation, early stages, non-invasive implant, compliance to follow-up, yes, go for a conservative. Unilateral BOT, the bilateral BOT, unilateral BOT, then go for a salpingo-oophorectomy, bilateral. Then if you try to conserve the healthy ovarian tissue, you can in that. But if you extensive disease, age more than 40, not interested into the fertility, much more, invasive implants are there, and patient wants to, want complete this thing, then go for a radical treatment. And definitely a malignant tumors, they are for a radical treatment. The follow-up should go with the clinical examination, ultrasound, and CA125 levels. So this is for this thing. So I would like to end my talk with the never stop learning, because life never stops teaching to you. So life's learning is a process, and for the medical professions, their learning is, I think, till the last breath. Every patient teaches you something. Every patient is new patient. So whatever experience, expertise are there, we should always, go for that. Personally, whenever, till now also, if I have to operate, I have to manage, I always see this is a new case, and I go right from A to Z, all the things. I never skips, or I never feel that I'm more experienced. I never feel that this is, because always surprises are there. Nobody is complete, perfect. And in oncology, you have to, when you are treating with that, because here the quality of life is very, very important. It depends, everything is depend on your clearance of the surgery and how you can give the quality of the life to that. And for this, in all these oncologies, these borderline ovarian tumors, they are very, this entity has come. And for the young patients, with the development of the so many things with the infertility, many patients, they are having having the dream of completing their fertility also, and they are going with the good quality life also. With this, thank you very much, everyone, those who have been listened to me patiently, and thank you very much, Dr. Ritu, a wonderful person, wonderful friend, a great academician, and one of the renowned, you can say, the IVF specialist. And thank you so much.
Dr. Rajeshri,
for everything. Thank you.
You are the icon for today, not me. Huh? So thank you.
Thank you very much.
Such a comprehensive lecture. Beautiful slides you have shown. Wonderful studies. Crab preservation के लिए तो मुझे कुछ बोलने को ही नहीं है.
You highlight. You should highlight in that, because I want to listen to you, because you are experiencing in that field.
No, such a nice presentation. No, in that you have covered each and everything. So means nothing has to be taken on. I have received some questions online. I think first we will take that, huh?
Yes.
Yeah, because lecture is very well appreciated by all. So I'm taking one question. So, hi, Dr. Shushila. Thank you for joining. You may not be able to see this question. I have received some via YouTube, huh? Dr. Rajeshri, huh?
Yes.
So, this question is by Dr. Shushila. She is writing, what are the consequences of persistent asymptomatic recurrent chocolate cyst? For more than it's a big question. Recurrent chocolate cyst for more than 5 years of size 4 to 6 centimeter.
Yes.
Second question, I will take 3 questions she has taken.
Okay.
Right, huh? Then you can answer one by one. Again, I will repeat. Huh? How to monitor such patients? What are the chances to get it converted to a borderline or malignant tumor in future?
Yes.
Yeah.
See, endometriosis is the disease which is involving spread everywhere. If suppose you have a benign chocolate cyst, so in that, where the recurrence comes in that, first time, if you are not taking it out the cystic wall, and some remnants of the disease are there either in the ovarian tissues or in a extra ovarian tissue, because extensively microscopic or macroscopic, which is adherent endometriotic implants are there. They have been whatever seeing with the eyes and possible that we can cauterize in that, but whatever left is that will, if we tackle with the treatment with the gonadotropin releasing hormone, GnRH analog or the agonist in that, so that will help, the completion of this. But what madam is saying is that there is a recurrence of that, and patients, complete the fertility and everything is over in her in that, and she is not responding to the medical line of treatment. Then I think the removal of that part of, this thing, it is advisable. Because if it is remain the disease like that only, there is a chances of going into the endometrial borderline ovarian tumors we have seen in that, and that is they don't have a very good prognosis like epithelial one, and because of this their tendency to adherent to every things, and if that implants it gets developed and it gets invasive type of the implants, then it becomes a very difficult. So but for young patients and recurrence 2-3 बार है तो चलता है, means you can treat it till she gets the thing. But extensively stage 3, stage 4 spreaded endometriosis also needed a complete line of surgical treatment for that.
Yeah, thank you, Dr. Rajeshri. Here I want to add, in some patients I have added the scabergolin.
Scabergolin,
so, yeah.
क्या scabergolin?
Yeah. So that gives in some patients, not in all patients. Whenever we are starting, we have to tell the patient the result may or may not come, because scabergolin is again a costly tablet. So 4 tablets are costing around 500 rupees. So again the patient can query कि ma'am इतना महंगा गोली खाया, result नहीं आया. But in some patients, yes, of course the results are coming. But recurrence is, of course, we can't say like that, He may or may not. One patient I operated 7 years back. So that time she was, I think, 21 years. 21 years, married at the age of the 18 and 3 years of the married life. So after that, we have done the AMH pre and post. And I told her ki better, the report was good. AMH was that time was around 3. So I told her, if you want to plan pregnancy, better you start, go ahead now. So you're already 23. So she told me, no, ma'am, I want to wait. Now she appeared today. That now from 7 years, the cyst was not there. And today, once I only done the sonography and I am able to find a cyst.
So this is what it happens in that, and patient becomes very, because for the endometriosis, I found the results with the post-operative GnRH analog good. But again, even with the scar endometriosis, it is very difficult to get in that, Sometimes we had one patient with this, somebody has operated and there was a scar endometriosis, not diagnosed also in that. And after that, I did a biopsy, because the different opinions they were coming, and it has pathologically diagnosed, and we gave with the GnRH analog. She was happy in that, and after that again symptoms. So this is what the endometriosis.
Yeah.
So sometimes they say ki endometriosis is a very difficult disease than the malignancy.
True. Dr. Rajeshri, your experience with the Dynogest for endometriosis, you find out the results?
The results are there, but I think patient's compliance is not for that. Much more in that, sometimes. So you have to counsel them sometimes, and so that is the thing in that. Some patients, they do like it, but the Dynogest we use in that. But continuous treatment, they don't like,
True.
We say for 3 months, then we extend for another 3 months. Then if they put on the weight or some other things, then the mood elevation, that is the one thing.
Yeah.
Which is
Correct. Agreed. Yeah. So let me see. Achha, till we receive more questions. So I'm coming to the rapid fire round. So Dr.
Oh.
Rajeshri, I'm able to see a very beautiful background on your screen.
This is a filter. Filtered because I'm sitting where the area the net was, because today there is a rain in Mumbai.
Yeah.
So in Mumbai, I have 2 connections of the internet.
Achha,
But you know, so last time what I did also, I did here half and I took half of from that. And this was matching. So I said, okay, cool. Even I am feeling cool. Cool background.
That's correct. So, so I'm coming to my rapid fire round. So you love rains, winter or summer? Which season is your favorite?
Rains.
Okay.
Last time winter. But I like both because summer is hectic.
Okay. Tell me one place where you have visited till now and where you want to visit again.
I like more that Bodh Gaya place, because that is our Gaya. I mean, that part of the things.
Meditation.
Meditating. I'm a meditator, so I go to Varanasi or those places are good.
Very good. And one of the place where till now you have not visited and you want to visit, your dream to go there.
So I can't say all places are good, but
ऐसा होता है ना कि कोई हमें ऐसी प्लेस होती है कि हाँ हमें वहां तो जाना ही जाना है. If some answer quickly, this is a rapid fire round. You are not supposed to take too much time.
Thailand once more.
Okay. So let's go together then, Thailand.
Yes, Thailand.
Okay. Yeah. So I'm receiving some questions on the WhatsApp. Just a second, I'm taking. Some doctors are sending on the WhatsApp. Meanwhile, if there are any questions, Dr. Stalin, you can take. My mobile is hanged. It's loading. Only 2 minutes, Dr. Rajeshri. It's loading.
No, I have a time actually.
Okay. What about your favorite color? Till the WhatsApp is opening, I will complete my rapid fire round.
I like all colors which is merged in the white. So white, if I say white, then means I like all colors.
Okay, great. Okay, that's good.
Because you know, white includes all colors, no?
Correct.
Rainbow.
Diwali or Holi, which is your favorite?
I like both because I born on a Holi Purnima.
How this answer everything you are saying?
I will tell you. I born on Holi Purnima.
Okay.
So that I like Holi also. But Diwali is nice.
Okay. I don't know what happened to my. I think it's raining heavily. That's why mobile is stuck. Not opening. मुझे ऊपर से दिख रहा था. Friends, meanwhile, if you are having any questions, you can ask. Dr. Leela has joined. Yeah, Dr. Leela, if any queries, you can ask here. Sorry, my connection is gone. This is working from the Wi-Fi and mobile is not working. I don't know what happened.
Connections are.
Yeah. So I think we will wind up for today. Yeah. So many thanks, Dr. Rajeshri,
thank you.
Giving your time to us and sharing your immense knowledge with all of us. So friends, next week, next Thursday on 11th August, again, we have a privilege to invite Dr. Rajeshri Katke Madam with us. She is going to discuss with us a very important topic, CA vulva. This is, we have decided till now. If you want to listen any other topic from her, please let me know by tonight only, because tomorrow we are going to shoot the flyer of the CA vulva. So if any other
says anything, whatever.
Yeah,
can-
so that's why I'm announcing openly the word, because madam is a master for all the onco surgeries. So whatever the details you want to learn from her. So I decided, because I myself have a lot of queries from CA vulva. So I thought
Okay. We will do that.
Okay. So thank you everyone. Thank you Shil Pharma. Thank you Sahiti.
Thank you, Sheel.
Dr.
Thank you,
Stanley.
Saiti. Thank you, everyone. Thank you.
Okay. Bye bye.
God
Good
bless
night.
you all.
Yeah.
Thank you very much.
Yeah.
Bye. Good night.
Bye. Good night.
Thank you, ma'am. Good night.